تيتانوس الكزاز، لأن المريض يكز على أسنانه. It is an acute disease induced by the exotoxin of the bacillus, which is a neurotoxin called tetanospasmin that affects neuromuscular junctions. Well, first of all, this is a gram-positive bacteria, and the gram-positive usually secretes exotoxin, while the gram-negative secretes endotoxin. This exotoxin is a neurotoxin that affects directly the neuronal tissue, and it's called tetanospasmin. And as you know, tetano is derived from tetanic, which is contraction. So tetanospasmin means continuous and severe contraction. It affects the neuromuscular junction, and as you know, during any impulse from the brain to the muscles to cause an action, there is a secretion of acetylcholine, which transmits the impulse from the nerve at the neuromuscular junction at the end of the nerve to the muscle to do the action. And this acetylcholine will transmit this impulse. At the same time of the secretion, there will be a secretion of acetylcholinesterase that will inhibit the effect of acetylcholine to stop the contraction, causing depolarization and stop the contraction, so that the muscle will not keep on continuous contraction. In case of tetanus, this exotoxin, which is called tetanospasmin, will inhibit the secretion of acetylcholinesterase, causing accumulation of acetylcholine, and of course this will lead to continuous repolarization and so continuous severe spasm of the muscles that will lead to exhaustion and will lead to most of the signs of tetanus. The tetanus bacilli usually grows anaerobically at the site of injury, and when we say anaerobically, we mean that it doesn't like oxygen, and more than that, it is killed by high concentration of oxygen. That's why in the treatment, the first thing we use high concentration oxygen, which is sometimes hydrogen peroxide, H2O2, to irrigate the area of the injury and cause high concentration of oxygen that will kill this bacteria. Clinical pictures characterized by painful muscular contraction, primarily of the masseter muscle, causing locked jaw. This is the first sign, locked jaw, followed by contraction of the facial muscles, the muscles of expression in the face on both sides of the nose and the cheek, causing what is called in Latin rhesus sardonicus, which means the devil laugh. Of course, it has nothing to do with the devil, poor patient, but there is a pressing on teeth on from the lower upper to the lower jaw with open mouth, and of course due to contraction, and this seems like a smile or a laugh of the devil, as they described before, and you don't know this poor patient whether he is smiling, laughing, crying, or suffering. And this is pathognomonic. Once you see it clinically, you will never miss it. Then the spasm will go, as you see, started from up, down, from up to down. So from the face to the neck, to the chest, abdomen, and then at last to the extremities, causing osteotonous position, And the last dangerous sign is reflex spasm, which is a severe continuous contraction of all the muscles of the body posterior to any simple impulse or any simple triggering action, like even a voice or opening the door or lighting the light and so on. This any action will cause the continuous severe spasm of all the muscles of the body, which will sometimes not stop until kills the patient due either to exhaustion or to paralysis of the respiratory of the chest muscle, causing respiratory failure, or even sometimes fracture bones, and most dangerous is fracture vertebra. That's why before we discharge the patient after treatment, if he improved, then we must do skeletal survey to all the bones of the body to see if there is any hidden fracture. Differential diagnosis, of course, according to the symptoms, starting with the locked jaw. Of course, the differential diagnosis here is dental abscess, for example, because it will cause also difficulty in movement of the jaw and locked jaw. If the contraction in the neck, then it will cause meningism like symptoms, contraction of the neck muscles, so should be differentiated from meningitis. If in the chest, the spasm of the muscles of the chest should be differentiated from Guillain-Barré. And if in the abdomen, then it may mimic the acute of the abdomen condition, and this is very serious because sometimes, especially when with inexperienced doctors, they may think that there is an acute abdomen and they may do laparotomy to the patient to see what is there, exploring laparotomy, and this is sometimes very dangerous, may kill the patient. And well, these are the main differential diagnosis that we need. The disease usually occurs after a history of wound or injury, and well, this is not the case always, because they found that sometimes there's no history of injury or any wound, even a trivial one. But in most of the cases, there is a history of a wound, especially deep or dirty wounds that cause the anaerobic condition, which is a good media for the flourishing of the bacteria. The severity depends on age. Of course, the extremes of age are more dangerous, like very young or very old. Site of injury, the closer the site of injury to the central nervous system, the more severe will be the clinical presentation. Size and depth of the injury, incubation period, the shorter the incubation period, the more severe the signs and symptoms, and the onset time, which is the time between the first sign, locked jaw, and the occurrence of the last sign, reflex spasm, which is usually few days, but when it is, for example, 48 hours or less, this means that we are going to see a very severe presentation, which of course is more dangerous. The causative microorganism is Clostridium tetani, which is a gram-positive bacteria. Diagnosis only clinical, we don't have any test for Clostridium. Occurrence worldwide, especially in agricultural and underdeveloped countries where contact with animals is high and immunization is inadequate, either due to failure in the health system or to low education and awareness of the population. Reservoir intestine of horses and other animals, and man, where the organism is a harmless normal inhabitant. Also, contaminated soil can serve as a reservoir. It's not only animals or man, even the soil can serve as a reservoir. And the spores, which are ubiquitous. Spores here are very important for the transmission and survival of this microorganism. Why? Because spores are very resistant to different environmental conditions due to its shell, and it can be transmitted for long distance by attaching to the bodies of birds like vultures, and it can survive for many years and waiting for the opportunity to mix with soil and get into the wounds, deep wounds of an injured person when there is a dirty wound contaminated with soil, and when it finds an anaerobic condition, it will hatch, flare up, and cause the disease. Mode of transmission: spores introduced into a wound contaminated with soil. Precipitating factors, of course, deep wound, because there is more chance of anaerobism. Poor blood supply, for the same reason. Foreign body. Necrotic tissue, also because there will be no blood and so no oxygen. Calcium salts, and local infection, because the other microorganism will be competing for the oxygen, the available oxygen, and so there will be no much oxygen, causing an anaerobism, which is excellent for this bacteria. Incubation period: 3 to 21 days. When we say 3 to 21, means that the least incubation period have been seen is 3 days, and the maximum seen was 21 days. Usually the mean is 14 days. Period of communicability: none, because there is no direct transmission from man to man. And susceptibility is general. Infants get passive immunity from vaccinated mother. Methods of control: first, preventive measures. Educate the public about necessity of complete immunization, because this is one of the diseases that can be totally prevented by vaccination, which is available, simple, and harmless. Second, universal active immunization. We have many schedules here. First, the routine schedule, that vaccine is given to the child in the first months of age, and of course the vaccine here is toxoid, as it's not live attenuated or killed microorganism. It is toxoid, which means diluted toxin, because the real effect of the microorganism is caused by the toxin. The routine schedule is during the second month, fourth month of life, sixth month, third dose, 3 doses, initial doses, followed after that by the boostering doses, 2 booster doses at 18th month and at 16th month, which means like 5 years, or it's called preschool age. Sometimes we give this vaccine to population at risk. For example, people work in agriculture or in contact with animals, and sometimes some countries give catch-up dose, which is after 10 or 15 years from the last dose, because this is a bacterial vaccine, not like the viral vaccine. Usually the viral vaccines stays for long time, sometimes very long standing, while the bacterial usually depletes within 5 to 10 years, sometimes more, but it will never stay forever. So we give a catch-up dose during adolescence at the teenage to the teenager, so that to uh, booster their immunity. Some countries give 10 years boostering continuous to avoid any risk. Wound management. We do what is called wound excision or debridement, and this is the main objective of this debridement is to remove the necrotic tissue, which is usually look black. You will learn that in future in your work. And necrotic tissue is a dead tissue, which means that there is no blood supply, and of course this presents a very good media of anaerobism to the bacteria. So the first thing we do when we receive a wounded person, and we are suspecting the possibility of development of or occurrence of tetanus, then we immediately wash the wound. We clean it by any antiseptic or any detergent, even soap and water may be enough. There is nothing else available. If there is H2O2 hydrogen peroxide, this will be perfect. We remove any dirt, because the spores are usually in the soil or in the dirt. We remove any foreign body, and we irrigate the wound with water and soap or any detergent. Go deep, and sometimes if there is oozing of blood, we better not stop this blood oozing if it is simple, because this will bring oxygen with it and causing aerobic condition, which will be not good for the survival of the bacteria. Sometimes even we don't suture some wounds if we are suspecting tetanus. And prophylaxis in wound management. After we clean the wound completely, then we will see what do we need here. This is the table of giving tetanus toxoid to the patient or immunoglobulin. And as you know, tetanus toxoid means vaccine, while immunoglobulin means passive immunity, antibodies ready-made. So, of course, the antibodies ready-made are faster than the vaccine, because the vaccine will induce an immunological reaction, which takes time, of course, few days. But if we are in a hurry and we are suspecting, and the patient came to us after a while of the injury, then there may be a possibility, or with deep or dirty wound, there may be a possibility of infection. So we may give immunoglobulin in certain conditions. And here you see TD. T stands for tetanus and D for diphtheria, because it's available sometimes as double vaccine, sometimes as triple DPT in children, but we use here in adults, for example, TD, and T is capital while D is small, because here we put small dose of diphtheria, don't use large dose. So TD is a vaccine, and IG is immunoglobulin, that is the passive antibody. Here, giving TD or IG, the choice depends on two main factors: history of tetanus immunization, which is very important, and the type of the wound. So if the history of immunization is uncertain, or the patient tells that he has 3 or less doses of the vaccine, and since a long time, then here we give vaccine. We better give vaccine to make sure that there will be some immunity in this patient. And this will depend on the type of the wound. If it is clean, minor wounds, then we give TD, but there is no need to give immunoglobulin. You see here, the type of the wound will determine whether to give immunoglobulin or not. So if it is clean or minor, then we don't need to give immunoglobulin, but we give tetanus toxoid if the patient has no history of more than 3 doses or he's uncertain. And in all other wounds, which means deep wounds or dirty wounds, we better give tetanus toxoid and immunoglobulin when the patient is uncertain about his immunization status, or he tells that he had less than 3 doses of vaccine during his childhood, if he ever remembers, of course. While if he had more than 3 doses of vaccine and is certain about that, or he has his own card of vaccination, then we again look for the type of the wound. If the wound is clean, minor wound, then we don't need to give toxoid or immunoglobulin. But sometimes we give toxoid if more than 10 years pass since the last dose of the vaccine, because as we said earlier, that the vaccine usually depleted after 10 years, and there is no harm of giving this vaccine. You can give it to anyone, even to the patient that has tetanus. After discharge from the hospital, we may give tetanus toxoid to booster his immunity, because the infection itself doesn't give a lifelong immunity like the viral infections. And in all other wounds, if he has a good vaccination status, we also don't need to give tetanus toxoid or immunoglobulin, unless there is more than 5 years since the last dose in dirty or deep wounds. There is no good satisfying history of vaccination, that is more than 5 years passed since the last dose, then we better give tetanus toxoid to be on the safe side. Control: report to local health authorities. No isolation, concurrent infection, quarantine, or minimization of contacts needed, because as we said earlier, there is no man-to-man transmission. Specific treatment: conservative. We usually focus on the main dangerous killer of the disease here, which is the continuous severe spasm that may cause severe exhaustion, fracture of bone or vertebrae, or paralysis of chest muscle leading to respiratory failure, and so on. So we give here muscle relaxant. Our main drug here is muscle relaxant, like diazepam, Valium in certain doses, also chlorpromazine, largectil, and phenobarbital, luminal. Of course, the dose is according to the drug, according to the age, and sometimes we even need curare in severe conditions, or when we have generalized spasm, we may need intubation or intermittent positive pressure ventilation. Antitoxin: after checking for hypersensitivity, we may give antitoxin, either human or bovine, but here we should be prepared for the possibility of hypersensitivity, because this sometimes may cause anaphylaxis in some patients, which may be very severe, leading to death. So we can't treat the patient from tetanus to put him in hypersensitivity reaction. So usually we check by giving very small, very diluted dose in the forearm of the patient, and see if there is any hypersensitivity. If not, then we give the antitoxin And if there is a hypersensitivity, then we do desensitization by giving continuous small doses diluted to less than 1% or sometimes 1 per thousand, and increase the dose continuously every now and then until we reach the dose, until we because in this case and in this process we will induce the immune system, and there will be desensitization to the antitoxin. And just in case, we usually put the antihistamine or antihistamine or hydrocortisone in one hand, just in case that any hypersensitivity reaction symptoms appear, then we can deal with it. Of course, this antitoxin is to neutralize the circulating toxin in the blood, not in the tissue, because once it goes to the tissue and binds to the cells, we cannot deal with it, we cannot remove it. But here, as you see, the most important is to deal with the killer, not the microorganism, but the toxin. And then we deal with the microorganism by giving antibiotics like crystalline penicillin or metronidazole, which we need to give it sometimes for 7 to 14 days intravenously. Tetanus neonatal. Well, from its name, it is tetanus of the neonates. It is a very serious health problem because each year we have at least 500,000 deaths of infants, of young innocent infants that should not die if we have a good preventive health system. And it is very important because the case fatality rate is very high. Actually, it's extremely high. That is in the best health facilities and centers in the world. It is more than 80%. So you can imagine that in other centers it may be 100%. Causes: dirty instruments, dressing and management during delivery. And this usually occurs when the delivery happens at home, especially in agricultural or rural areas where there is no local health facilities that can do this job. Then the people by themselves, the oldest woman, which is called the grandmother in the family, will do it as they consider her more experienced, and so they will use any dirty instrument like the scissor, or more commonly that cause the disease is dirty clothes or dressing that could be contaminated with soil. And sometimes they even in rural areas and where there are animals, they may use the excreta of the animals to put it on the umbilical cord. And as we said before, the excreta is very rich in spores of microorganisms, and because it is inhabitant of the intestine of these animals, and so we will bring it and inoculate it into the blood directly into the open umbilical cord stream, and so we will cause tetanus neonatorum and will kill the neonate. Clinical picture: normal neonate in the first few days of life. Why normal? Because, as we said, the least incubation period is 3 days. So anything less than 3 days, and the exposure, of course, occurs not when the child or the newborn or the fetus was intrauterine. No, it occurs during labor, during contamination after labor. So the incubation period should be at least 3 days. So anything happens, any symptom, similar symptom before 3 days, it may be due to a congenital problem like hypernatremia or hypocalcemia and so on. So the symptoms will be crying, reluctance to feed, generalized spasm with whistling expression. The neonate looks like he is whistling, and I will show you a video about that to see it, and once you see it you will never miss it again. Prevention: improving maternity care in the hospitals, and this includes all the details of maternity care. 2. Active immunization of mothers. We give tetanus toxoid to the pregnant mother, the pregnant woman, during the preferably fourth month of pregnancy. Sometimes we can give it at the 5th or even 6th month if we didn't catch the pregnant woman, but not more than the 7 months, because there will be no time for the vaccine to induce immune response, and so it will be useless for the child. Because here we are giving active immunization to the mother not only for her sake, it is primarily for the sake of the child, so he will gain immunity from the mother, and he will gain antibodies while he is still in the intra-uterine period. So the 4th month, the first dose, then after 1 month from this dose, the second. So these are 2 doses before delivery, and then you see here why we don't give it after the 7th month, because these are 2 doses, and if we give at the 8th and the second at the 9th, there it will be useless. And the 3rd dose is 6 months from the 2nd dose, which means after delivery, when the mother comes to vaccinate her child for DPT or polio or other vaccines during his 4th or 6th months, then we will catch her and give her the 3rd dose, and then the 4th dose after a year from that, and the 5th after another year from the last dose. And with these 5 doses, we will complete the immunization of the mother for the sake of her child, and so this vaccination and immunity induced by it will stay for many years. So most of the times we don't need to give another course of immunization during the next pregnancies. This one, if is given properly and completely and in its time, then it will be enough for all the coming pregnancies. Encourage deliveries at hospitals to avoid any dirty conditions and contamination, and train and educate midwives and control of birth attendants. Of course, the midwives are more knowledgeable and more expert than the birth attendants. Birth attendants, as we said, are those who are not qualified or authorized to do deliveries, but there are no one but them, and delivery and labor is an urgent situation, so they do that. So sometimes we cannot stop them from doing that because they have no other choice. They cannot tell the child to stay until reaching the hospital, which may be sometimes very far away. So the least we do to lessen the problem and complications, we bring those birth attendants, we train them in the hospital for a few days, we teach them, most importantly, how to have clean labor with clean instruments and dressing, and sometimes we used to give them antiseptics and cotton and scissors and complete bag with all the instruments that they need in delivery, just to encourage them. But we tell them that if any case of tetanus neonatal discovered and registered in their territory, then we will punish them, because this is a life of a person. Thank you.